The FINEARTS trial, finerenone in heart failure with mildly reduced or preserved ejection fraction. Despite the availability of several therapeutic options in heart failure with mildly reduced or preserved ejection fraction, there remains a high unmet need in this population. Steroidal mineralocorticoid receptor antagonists reduce morbidity and mortality in patients with heart failure and reduced ejection fraction. Their efficacy in those with HFmef or HFpEF has not been definitively established. Finerenone is a non-steroidal MRA, which compared with steroidal MRAs is more selective for the MR receptor, has a shorter half-life, and has a more balanced distribution between the heart and the kidney. FINEARTS was a randomized, double-blind, placebo-controlled trial testing the hypothesis that finerenone would reduce cardiovascular death and total worsening heart failure events in patients with heart failure and mildly reduced or preserved ejection fraction. 6,006 patients were randomized to either finerenone or matching placebo. The target dose was based on the baseline eGFR. So if the eGFR was below 60, the target dose was 20 milligrams. If the eGFR was greater than 60, the target dose was 40 milligrams. They were followed for a median of about 32 months. So these were symptomatic patients with heart failure and ejection fraction of 40% or more. They could either be hospitalized, recently hospitalized, or ambulatory. They had to have had elevated natriuretic peptide levels and evidence of structural heart disease, and were treated with diuretics within 30 days of randomization. Patients were excluded if they had a potassium greater than 5 or an eGFR less than 25, or if they had alternative causes to explain their signs and symptoms. Here are the baseline characteristics. As you can see, they are well balanced between the treatment groups. A characteristic patient population for heart failure with mildly reduced or preserved ejection fraction. The mean age was 72 years. 45% of patients were women with a good geographic distribution. 79% of patients were white, 17% Asian, and very few black patients. The majority, 69%, of patients had NYJ class 2. The mean left ventricular ejection fraction was 53%. 60% of patients had a prior hospitalization for heart failure. 40% had diabetes, 30% had atrial fibrillation, and the majority of patients had hypertension. There was a high percentage use of loop diuretics, beta blockers, ACE inhibitors, and ARBs. About 9% of patients were on ARNIs, and 13.5% of patients were on an SGLT2 inhibitor at baseline. 20% of patients were enrolled within 7 days of a worsening heart failure event, 34% were enrolled between 7 and 3 months, and 46% were enrolled either after 3 months beyond the worsening heart failure event or they had no prior worsening heart failure event. The mean ejection fraction was 53%, with 19% of patients having an EF over 60%. 45% had an ejection fraction between 50 and 60%, and 36% of patients had an ejection fraction under 60%. Here are the primary results. Finerenone reduced cardiovascular death and total worsening heart failure events over a median follow-up of 32 months, yielding a rate ratio of 0.84 and a p-value of 0.007. There was an absolute rate reduction of 3.3 per 100 patient years. The first secondary endpoint was total heart failure events. This was reduced by 18% with a p-value of 0.006. Both cardiovascular death and all-cause mortality were numerically reduced, but it did not reach statistical significance. The point estimates in both cases was 0.93. Efficacy finding was consistent across all pre-specified subgroups, and this included the subgroups based on ejection fraction at baseline and whether or not patients were receiving an SGLT2 inhibitor at baseline. There was no evidence of heterogeneity for any of the 17 pre-specified subgroups. There was significant benefit with respect to the change in the Kansas City Cardiomyopathy Questionnaire Total Symptom Score, suggesting improvement in symptom burden. It was 1.6 points. There was no evidence of significant improvement in NYHA class. With a very small number of renal events, there was no significant difference in the composite renal outcome. With respect to safety, finerenone was well tolerated. There were a similar number of serious adverse events in the finerenone group and the placebo group. There was more hyperkalemia in the finerenone group, whether you look at serum potassium measured or investigator-reported hyperkalemia events. However, there were very few episodes of hyperkalemia leading to hospitalization and no episodes of hyperkalemia leading to death. In conclusion, among patients with heart failure and a mildly reduced or preserved ejection fraction, finerenone reduced the risk of the primary composite outcome of cardiovascular death and total heart failure events, reduced total heart failure events, and improved overall health status. These findings were consistent across pre-specified subgroups, including left ventricular ejection fraction and baseline use of SGLT2 inhibitors. Hyperkalemia was more common in those receiving finerenone. These data support the use of finerenone in patients with heart failure with mildly reduced or preserved ejection fraction.